You can press *7 to unmute.
This is a topic of great importance, and I want to thank SNTC and Dr. David Ashkin for starting this webinar. Dr. David Ashkin will be in charge of Q&A today, and he's the Medical Director of the TB Control Section for the Division of Disease Control and Health Protection, Florida Department of Health, and also the Principal Investigator at the Southeastern National TB Center. As our first presenter, we have Dr. John Jarab, who is with CDC's Division of TB Elimination in the Field Services and Evaluation Branch here in Atlanta. And he will be presenting the national perspective, the CDC perspective, on PPD tuberculin solution shortages. After that, we'll have Dr. John Workington, who's a State TB Control Officer and Medical Director of the Tennessee TB Elimination Program. Also serves as the current president of the National Tuberculosis Controllers Association, and he's going to present the same topics from the state and local perspective. After that, we're going to have Dr. Richard Brostrom, who is a CDC Medical Officer in the Field Services and Evaluation Branch, who is situated in Hawaii as a TB controller, and also provides assistance to the 6 U.S. affiliated Pacific Islands. He's going to talk about some specific issues that Hawaii has grappled with in the last several months regarding to the PPD shortage. Then we'll have Dr. Margaret Oxtoby, who's also a medical officer with the Field Service and Evaluation Branch, DTBE, but situated in New York State. And she will be addressing similar issues of how her state has dealt with the challenges related to PPD shortage. We'll have plenty of time for questions and answers, and there's a lot of polling questions as well in between, so we can get the flavor of what's happening in the nation and what's going on and has happened for the last several months. We also have Steve Richardson, who is a representative from one of the pharmaceutical companies, JHP, Applesol manufacturer, on the line, who will be listening in. So why don't we go ahead and take the first 2 polling questions to start off, and then we'll have Dr. Jarab give his presentation. So let's go with polling question number 1. What best describes your job responsibilities? Okay, we do have 470 lines participating, so going to wait a little bit, to just another 30 seconds here while everybody rings in. All right, I think we should probably go ahead and close this poll because we have lots of questions, so go ahead, let's close it. Unless, I don't know, Dave, do you want to wait a little longer?
You can go on, Sundry,
Okay.
that's fine.
We've
Do you
got
want
the
to
flavor.
Great. Would you like your next polling question?
Okay, fantastic. It looks like about 50% of you on the line today are nurses in public health programs. We also have some representation from the other categories. Okay, excellent. Let's go to the next polling question. Okay, so in your guesstimate, do you think most testing for LTBI or screening for LTBI is done by public health facilities in your community or non-public health facilities? And that would include the private sector, academic institutions. Okay, it looks like it's roughly 60-40. Okay, that gives us a kind of a good idea of the practices in your community. All right, so let's go ahead and have Dr. Jarab present.
So, good afternoon in the East, good morning in the West. Pleased to talk to you today. I'm going to give you a broad overview of this shortage from our perspective here at the TB Division CDC, and also share a little bit of information about PPD tuberculin solutions for skin testing. Back in November of, next slide please. Who's doing slides?
Oh, I can do them. Hang on.
Thank you. Good. So back in November of 2012, we began to get calls that the 50-dose vials of PPD brand Tubersol were unavailable. By December, we were getting more of those calls, and also we were hearing from a few jurisdictions who were falling back on the 10-dose presentation of Tubersol that it was also becoming hard to find. By January of 2013, Aplisol's supplies were running low in some jurisdictions because providers are switching from Tubersol to Aplisol. Also in January of 2013, we were officially notified by Sanofi Aventis, that's the producer of Tubersol, that the 50-dose vial was unavailable. I didn't show in this list of dates here, but in February of 2013, Sanofi notified us that their 10-dose vials were going to go on allocation for orders, but in fact they were largely unavailable in many jurisdictions. In April of 2013, JHP Pharmaceuticals, that's the producer of Aplisol, notified their customers of an allocation scheme because their supplies are running low, probably because the demand pressure as Tubersol was unavailable. And in April of 2013, Sanofi Aventis sent a notice to customers, the FDA and CDC, that the 10-dose vials were again available, but only by direct purchase. They were also supplying them to wholesalers, but the distribution time going through wholesalers and distributors made it easier for Sanofi to supply directly to customers to make up for the long-term gap. Next slide, please. So let's talk about tuberculin skin test antigens a little bit. There are two products approved for use by FDA in the United States. The first is Tubersol, made by Sanofi Pasteur Limited, and the second is Aplisol, that's made by JHP Pharmaceuticals. These two antigens have comparable behavior in CDC-sponsored clinical studies. I know the mythology. If you ask the average public health practitioner on the streets about these two antigens, that person will say Tubersol is better and Aplisol costs less, but in fact, if you compare them rigorously under good standardized conditions, they behave almost identically. Both the antigens have to be standardized against PPDS. PPDS was developed in the 1940s. The S stands for Siebert, as in Florence Siebert. She made a huge batch of this stuff and turned it over to the U.S. government, and that batch that was made in the 1940s lasted all the way up through the 1990s. That's a long time. But the lyophilized product of PPD is very stable if it's kept under tight, well-controlled freezer conditions. And indeed, because it's so stable, a batch can last for years. The last time I checked, manufacturers were making a batch about every 7 to 10 years, but I don't know what the recent practices are. For a little humor here, I've said that a good tuberculin solution is hard to find. Now, you or I could make PPD tuberculin. You could go to a library if you're a microbiologist and read about how to mix it up, and you'd get a PPD tuberculin, but it probably wouldn't work very well. The procedures for producing the batch of tuberculin have to be very precise. The temperature, the control of pH, the timing, the exact reagents that go into the growth broth. And then once you get your PPD tuberculin, the standardization to make it a really good and precise tuberculin is very slow, and it's expensive and time-consuming, and that's why we don't have more tuberculins floating around now. In the good old days, some state health departments used to make their own PPD tuberculin. Because it is fairly easy to make it, it's just hard to make it well. Each time a lot is prepared from an original batch, it has to meet strict specifications that are monitored by FDA. Next slide, please. So the national response to this shortage has been kind of broad and general. Certainly we've been following it and collecting information from you as you notify us. And we've worked with FDA and some private entities such as the pharmaceutical companies. We've also given a lot of ad hoc responses to the questions that have come to us through CDC Info, through our program consultants and direct communications with many of you who are on the line. In April, we sent out a health alert notification, a CDC info service notice that was called Nationwide Shortage of Tuberculin Skin Test Antigens, and that gave some general guidance. And we reiterated that guidance with a little bit of update in an MMWR on April 26. Next, please. The broad guidance that we issued were that you could substitute the IGRAs for the blood tests for skin tests, but there are some shortcomings to doing that. There are cost shifts. In general, IGRAs are going to cost more than skin tests. Not all of you have IGRAs available to you because of either problems with phlebotomy or getting laboratory services. And many clinicians are not experienced with IGRAs yet, and the interpretation is somewhat different than for the skin tests. We also suggested the possibility of allocating skin tests to priority indications that would be determined by the local public health authorities. We had to make that guidance very broad and general because it really depends on what's available to you and what your needs are in terms of patient care and the policy implications. And then finally, we suggested that you could substitute Aplosol for Tubasol, but in saying that, we already knew that for a lot of the jurisdictions that were dependent wholly on Tubasol, there weren't any readily available supplies of Aplosol. And indeed, Aplosol is under allocation, which I believe followed some of their historical distribution practices. I'll close by saying that we only gave very short notice to FDA, the Center for Biologics Evaluation and Research, or CBER, and they were not able to find somebody to staff this webinar today, but they did ask me to read this note to you that the FDA is interested in hearing about the nature of the questions that are being asked here today. They want to learn about what the public concerns are and to develop more materials for the public as needed. And I have agreed to pass along any questions that are relevant to their work, and we'll find a mechanism to get the information back to you after FDA responds. Thank you.
Okay, thanks very much, John. Excellent presentation. I think we're going to take a few more polling questions at this time. So why don't we go with, yeah, this is one. Okay, great. So if you were, let's see, is this one on? Yeah, if you were primarily using TST for LTBI testing prior to the shortage, which project did you primarily use? Okay, I think most people have rung in right now. So it looks like the majority of full, sort of 85 to 90% of people or programs are using Tubasol over Aplosol. Okay. All right, let's go to the next question, please. Since the announced PPD shortage, have you been able to obtain TST antigen?
So Sanjay, this is Dave Ashkin. Something very interesting as we're looking here. It looks like at least 20% of people, despite the shortages, it seems that they've had no problems, that they've had no noticeable change in supply, which is really interesting. And about 50% have had some limitation to their supply. So it's really affected, as you can see, the vast majority. But some people say they've had they've had no problems.
Yeah, and the same percentage, almost 17%, have not been able to obtain TST antigen at all. So it's interesting. And I'm wondering if this reflects where the programs are located or what the size of the program is, or it would be interesting to know, but we're not going to find that out through this question.
Exactly. So let's see the next one.
Okay, if you're able to receive PPD antigen, how are you obtaining it? So it's limited to those 80% who said they were receiving TB antigen.
I got to say, Sundry, I really like the people who are getting it from the guy on the corner because it's really keeping my kids fed. So thank you for buying.
There you go. That's 7% of people. At least have a sense of humor. That's good. Okay, so it looks like the majority of people, again, 64%, are getting PPD antigens through their usual wholesaler, but that good 25% are actually using Sanofi's recent program that we circulated to all, and then 3% through the allocation program. Okay, why don't we go to the next question? Are you using the TST antigen you have available beyond the recommended 30 days once the bottle is open? And the reason we put this question in there is simply because a lot of people have asked it, whether they can do that or not. Right. And according to the label, you cannot.
And just real quick, I mean, thanks for chatting, guys. We appreciate it. We're looking at it. One of the things on the other questions, one participant was saying that they actually ordered the TST antigen from the Sanofi program, but it's now costing, they're saying, much more, and plus there's a shipping cost. So that's also another implication that is occurring that I guess we're learning more about. But as you said, Andre, this whole issue now, using it beyond 30 days, I mean, I think a lot of people are trying to figure out how to stretch what we have. But again, reminding a lot of people that this is not FDA approved, and we really don't know how well it performs outside that 30 days. But again, we want to thank those individuals who sent us questions prior, so we can make sure we answer those questions. Thanks.
So, and it does look like the majority, 93%, are not using it beyond that the recommended 30-day period. So, okay, good. Why don't we move on to Dr. Warkentin's presentation now? I think that's where we are, right?
John, how's it going?
Hi, this is John Warkentin from Nashville, Tennessee. I hope everyone can hear me.
Yes, we can hear you.
Okay, confirmed. Thank you. First of all, I'd like to thank the Southeastern National TB Center, Dr. Ashkin, for the invitation to offer a few comments on this webinar. As Dr. Jareb said, nearly anyone can make some TPD solution. We in Tennessee have a very rich history of brewing our own and delivering at high speeds. And however, we don't recommend that in this situation as a solution for your PPD shortage. I will be wearing two different hats as I briefly comment today. First is the TB Control Officer for Tennessee, and then secondly, as the President of the National TB Controllers Association. The impact on states and local health departments of this shortage is similar in a way to what we've been experiencing with the isoniazid shortage. It's impacting all the states and probably most public health jurisdictions across the country. Clearly, it has an impact on the diagnosis of TB disease as well as on our evaluation of contacts and targeted testing to the extent that that has been implemented around the country. And all of us, I'm sure, have been receiving calls, and more calls about what to do when one of our standard tools is in very limited supply or completely unavailable. in our experience here, congregate settings in Tennessee have been greatly impacted, and that includes prisons and jails, shelters. We've gotten calls from various A&D treatment facilities, from a mental health hospital, and a host of other congregate settings. And moreover, there are infection control professionals at hospitals and ID docs, folks at dialysis centers, even transplant clinics in Tennessee, who've been asking about what to do with the limited supplies of Tubosol or Aplosol, if they have that, given the shortage that we have now. And then not the least of our issues has been a multitude of questions coming from occupational health about how to screen and test individuals who may be at occupational risk for TB infection. The next slide here shows a memo that went out from the NTCA Corrections Committee, and one reason for showing this is just to give a shout out to all the good folks on the NTCA committee who put this together, recognizing the great need that correctional centers around the country have in this regard. They do an enormous amount of TB screening in terms of risk assessment and placement of TSTs using one or the other of the two products that have been in shortage. So this provided a heads up that this issue was brewing and accelerating, and also providing some guidance for how to respond. How has the shortage impacted public health departments? Well, first of all, it's impaired our capacity to test for infection with Mycobacterium tuberculosis. And we've essentially all faced similar choices here to make, and the consequences of choosing one of them. For example, restricting the usage of PPD stock, which obviously puts some folks on a waiting list who may be at a higher risk and could certainly benefit from testing. Switching PPD products, for example, to Tubosol, from Tubosol to Aplosol, has been, I think, a widely used option. And a third has been purchasing an interferon gamma release assay, either the QuantiFERON TB Gold in-tube test or the T-Spot TB test, both of which involve specialized laboratory analysis to complete the test and logistics of drawing the blood and appropriately shipping and handling, as well as the cost associated with it. I think all local and state health departments that use either of the two products for the TST has lost a significant amount of productivity due to fielding hundreds of calls of different organizations looking for PPD stock and addressing the appropriate use of these supplies. The cost to TB programs, due to the lack of access to these products, is not insignificant. And sometimes I think we overlook the cost to patients themselves who may be put on a waiting list for testing, and also the cost to them for taking time off, first of all, to even have the test placed or read. Ironically, this situation, I think, has also brought some interesting opportunities for provider education in our communities. And I hope that we hear more about that from others on the call. We all, to a certain degree, have been relying on the TST, which is one of our tools that is now over a century old. Many of us have believed, up to this point at least, that this tool is the least expensive tool in our public health setting for testing for Mycobacterium TB infection. However, it takes 2 visits, and there are somewhat subjective results in terms of measuring the results if you're able to get that patient back for a second visit. The cost of evaluating false positive TST results is not insignificant, as well as the cost and risk of treatment to patients who may have had a false positive TST. But it's still useful in many situations. First of all, in evaluating persons with suspected TB disease, evaluating contacts for infection with MTB, and for targeted testing in high-risk populations. However, that said, we in our own state are fully aware that there is both systematic and random testing going on of low-risk individuals using the TB skin test. And I would go further to say that probably several thousand individuals in our state are inappropriately tested using a TB skin test over years' time. So is it time, I'd just like to raise this question to the audience here today, is it time to reconsider our overdependence in public health TV programs on the use of the TST, as well as to consider inappropriate use of the TST in our programs and elsewhere? The TST is an imperfect tool of our trade. It's an indirect evidence of infection with MTB. While it's useful as an adjunct to the diagnosis of TB disease, there are a number of situations in which it simply is not reliable. We have negative TST results sometimes. However, they do not, such results do not rule out TB disease. And on the other hand, a positive TST does not confirm TB disease. Similar to this, we all know that the AFB smear results from smears do not rule out TB disease. They're helpful when they confirm, but certainly do not rule out. There is no gold standard for detecting infection with MTB. So how do we really know? How do we decide if it's a false positive or a false negative? And then, are the newest kids on the block, the IGRAs, better tools than the TST in providing us with a standard? And I will not provide the answer to that question. Frankly, I don't know, and I'm not sure that anyone else knows at this point. I would like to highlight, though, the value of the risk assessment process. And I think that in what we do, it's critical that this process be emphasized more in our decision-making about whether or not to place a TST or alternatively to use an IGRA test. So this is a test that is based on, it's a tool that we use based on surveillance data, which should be locally defined, although we use some national data. It should be really locally defined in terms of making our decisions about the use of tests. And the risk for exposure to MTB is also critically important, as well as the risk for progression to TB disease in terms of the assessment process. We should implement a risk assessment in our decision-making, and omitting it leads to confounding results of TSTs. And we sometimes make decisions about going ahead and doing full evaluations and treating folks who may have a positive TST result due to non-tubercular mycobacterial exposure, for example, or other causes. So the question I would like to raise is, why do we continue to place TSTs on low-risk individuals? And if we don't already, why do we draw IGRAs on low-risk individuals? Are we now seeing the demise of the TST? I don't know. Perhaps somewhat. In the meantime, as we're trying to sort out that question, I think it's critical that the supply be stabilized, that access be assured, and that the cost of the PPD solutions remain reasonable for public health programs across the country. I think we all need to renew our commitment to doing a risk assessment before using either one of these the tests, whether it's the TST or the IGRA, and to stop testing low-risk individuals for with either a TST or IGRA. There's excess cost involved. There's risk to the patient if we go ahead and treat for what may actually be negative results. And we need to insist, I think, and as we provide community education with our colleagues in hospitals and other healthcare settings, on what the standards are for public health practice with these tests. Another aspect I think we need to take a close look at and work toward is equity. That is, to ensure that all high-risk individuals have access to the best tests available to us. Are there better tools available now? Well, maybe yes, maybe no. It's a toss-up, and there are risks and benefits associated with each of the two categories now. So I think that it is critical that development of other diagnostic tests continue. Whether there's an incentive to do that, I don't know, but I think it's absolutely essential for us to more cost-effectively
Sundry,
Okay, yeah, go ahead, Dave.
this is Dave. I mean, I think that's really interesting that it's interesting here. You can see almost 40%, despite the PPD shortage, really have not, really looks like re-examined their LTBI testing policy. Now, a lot of that may be that they've already looked at it before, prior to the shortage, and they've already kind of, I guess, reassessed who they're screening. But I think that's pretty surprising.
Yeah, I think that's probably the case, or maybe after this webinar they're going to look at their LTBI screening policies. But interestingly enough, 60% are, and that could be the positive impact of all of this, is exactly what John Workington was saying in his presentation, that we really need to now look to see that we are targeting those at high risk for testing. And we are going to hear in our next presentation about ways in which Hawaii is doing that right now, and New York. So let's go to the next polling question. Okay, in your opinion, is there a significant amount of low-risk LTBI testing being performed in your community? This will help us address what you just brought up, Dave.
Yeah, I agree. I mean, I think, whenever there's, an impact or something that happens to a program, it's always a good thing to stop and reassess. I mean, that definitely happened with INH, and I think it's very, very important that it happens now with the skin test, the antigen shortage.
So this is interesting because it looks like there's only a 10% difference from the response to the last question, suggesting that those programs that do feel that there's a significant amount of low-risk testing being done are the ones that are addressing their policies.
And one of the things I'm seeing on the chat, and first of all, thanks for chatting, guys. But one of the things you're seeing, which I think is true, is that some people are saying that some of the policies are being driven by the Department of Health in their areas, where the Department of Health may really be dealing with a different population that they're seeing in their facility. And I think that really stresses the importance that it's really, the decision to test is really based on your local, and I mean local, risk and assessment.
Yeah, I think that is true, and I think that's what our guidelines say as well. So why don't we go to the next polling question? Is routine LTBI testing a requirement for students in your community?
And I think these next couple of questions are really trying to address some populations that maybe in your community may not be high risk, but yet they're still being either mandated or recommended, and that's causing a lot of stresses. And we're going to address a lot of these stresses in these different circumstances and situations, but we want to get an idea of how many different situations, and how they're differing in our participants.
And probably we could have included a question asking whether a risk assessment questionnaire is used even in these populations prior to testing.
And Dave and Sundry, some people are asking, are you talking about college students or healthcare students or public schools? Do you define that?
I think any of the above. You're 100% right, Donna. I mean, a lot of areas have for just getting into public schools or the primary schools.
Right.
They need to be tested. But again, at least in Florida, I think one of the things we're going to talk about is that these tests have their limitations, and that's why whenever you're doing screening, you always want to screen, as Sundry is saying, with a risk assessment. And you're right. I think we may have been better off if we asked the question, if we are requiring it, is it being done with a risk assessment or the requirement for a test? You're right, Sundry.
Yeah, and I think this also speaks then to John's point that you screen these people, let's say all kindergartners who start the school year, and then you end up potentially treating patients that don't need to be treated. And there is definite risk to individuals. Okay, so 50%, over 50% of the communities the people represent here, students are required to be tested. Let's go to the next question. Okay, same question except for food handlers in your community.
And here you see a difference, and I think this is a major change over the last 20 or 30 years, where many communities had requirements for food handler testing. And you see here, at least the majority seems like there is no screening, and I would take screening meaning either risk assessment or LTBI for food handlers.
Okay. Yeah, we're seeing very different results here, as we would expect, but still 11% of those in the line are responding, or those who respond to this question are stating that that there is testing requirement for these food handlers. Okay, next question. Same question, is routine LTBI testing requirement for retirement or long-term care facilities in your community?
And here you're seeing a difference again. Here you're seeing the vast majority do have that requirement, and we're going to talk about that a little more specifically after Dick and Margaret talk about their experiences and use their experiences kind of a springboard for further discussions. But I think you see here that the vast majority looks like do require it.
Right, and that's probably what we would have predicted.
And again, what's interesting, it says here LTBI testing, not risk assessment. So I wonder if, but I think I agree with them, at least in Florida. A lot of our long-term facilities do have that requirement.
PDH is correct.
Right, so let's go on to the next question. For those populations that are low risk but where LTBI screening is required, have you postponed LTBI testing due to the PPD shortage? Yes? No, we're using I-grade testing, or no?
And Sundry, here I think you're seeing here that interestingly enough, I mean it's very close. I mean you're seeing that almost close to 50% have in fact stopped or at least they postponed their LTBI testing, but seeing 6% that have switched over to IGR and 45% that have not postponed it.
This is really split between yes and no. Interesting. So again, I think Dick and Margaret are going to speak to this, but there's probably some legislation that's involved that drives the testing in these groups.
Without a doubt, and that's very, in some ways, somewhat, it ties a lot of our hands, that even if we wanted to postpone it, we would run into problems with regulations.
Okay, well that was really interesting, and I think we're going to turn this over now to Dr. Richard Brostrom from Hawaii to discuss what's going on in his state right now.
Good morning, can you hear me?
We can hear you, Dick, thanks.
Great. Okay, good morning. I'm still in my first cup of coffee here. But before I start, I have to warn you that both my two dogs and my two teenagers tend to bark around this time in the morning. We'll try to get through this undisturbed. In the next 10 minutes, I'd like to review our state response to the current PPD solution shortage, and we'll talk about the current status of TB screening in Hawaii, Hawaii's response to the PPD shortage, and then maybe something we'll call the silver lining. So, Honolulu, Waikiki Beach. It is beautiful, but it's crowded. And it's not crowded just on the beach. Oahu County counts as the 10th largest city in the U.S., and it is a state of immigrants. Over the last 5 years, we've had the highest TB prevalence in any state, and 9 out of 10 cases in Hawaii were born outside of the 50 U.S. states. We think of ourselves as the Ellis Island of the West, and the health department has been battling high TB rates for many years. Consequently, mass screening for TB began in earnest in the 40s. Here was a successful project to screen 1,000 people per day with chest x-rays for 20 weeks. And I'm very glad I didn't have to read all those tiny little x-rays. Those efforts, however, were largely successful with resultant drops in TB rates. A 98% drop in TB rates in the 1920s was accomplished here in Hawaii. And we're still busy screening today. But as was mentioned already, some of our screening requirements are now fairly out of step with the U.S. mainland. Although,
Dick, I think there's some request that you speak a little louder.
Okay.
Thank you.
Is this any better?
Fine for me here. I don't know, Dave and Donna, are you hearing him fine?
We're good, Dick. Thank you very much.
Should I march on, or do we need to go backwards?
No, march on.
Okay. So our students are certainly over-screened, as are our food handlers. 100% screening for all food handlers still exists in the state. Worse, the method for screening is hard-coded into our state law. It's TST-only country in Hawaii, and I know some of you have dealt with this as well in your states. Hawaii laws specify TST and that the cutoff is 10 millimeters. There are no exceptions. IGRAs are not allowed to substitute for the TST. Risk-based screening is not allowed, and there are no religious exemptions to TB screening that are allowed. So if a child from Montana comes over to start school in Hawaii in 3rd grade and they bring a 2-week-old IGRA, they are told that they cannot attend school until they undergo a skin test. Not surprisingly, the community, several folks have challenged the state on that, but the state has withstood several court challenges because the law is so clear. The result is that over 1,000 skin tests are placed every week by the Hawaii Department of Health. We do more than 50,000 skin tests every year. Half of them are done in our clinic in downtown Honolulu. This slide reveals some of the results of 10 years of screening for our state program. And these screening efforts have yielded 10 to 15 new TB cases every year, around 10% of our annual caseload. And you can see that the rate of TB disease per 100,000 is actually fairly substantial. So we are aware that there is some value of all this skin testing done in Hawaii. We just need to aim it better. So now to the point. Our response to the skin test solution shortage has been mostly of recent. In December, we heard rumors, but we had no supply problems in Hawaii. In January, we ordered extra PPD solution, although we continued to have adequate stocks. In February, our state inventory was at its usual 8 to 10,000 doses, but it was very clear that the shortage was imminent, and we reported that to our administration with hopes that we could modify our screening methodologies. However, we were able to order in March another 3,000 doses of Alpasol to augment our current inventory of 5,000 doses of Tubersol. So that's about a 2-month supply, and we were told that Tubersol would be available by mid-April. And we comforted ourselves with the thought that we were going to be able to get through this without any adjustment in our current rules. In April, the state inventory dropped to 3,000 doses, and unfortunately our Alpasol order was halted due to a vendor not being compliant. It was a new vendor, and with all of the rest of the nation clamoring for a limited supply, the vendor understandably was not very interested in jumping through all of our hoops. So in addition, the date for the 50-dose vials was pushed to late May, and we got nervous at that point and decided it was time to pull the fire alarm and notify the state. So we met with the, in early April with the Attorney General, with the Communicable Disease Director, and we reviewed our options. And we came up with 5 different options. It looks like we're preparing a vote on these options, Sundari?
I don't know, Donna, did you do this
I
as
do.
voting?
Yes, I'll pull those over right now.
Okay,
ahead.
yeah, we'll have it.
I'll go through them first, and then you can pop it up there.
Okay.
So Plan A was an optimistic plan to change the state procurement rules so that we could purchase our Alpasol and get us through to the end of May. And we called the state procurement office, and after they finished laughing, I think, they let us know that that would take only a request from the governor to accomplish.
Dick, before you go through them, why don't we just have the vote?
Sure.
Let's do that, Donna. Okay, so before you're biased with the rest of the plans, go ahead and vote. What do we want to do? Read the plans out, because we can't read that.
So I'll read the plan. Plan B
Yeah,
is
go ahead and read them.
for the governor to declare a public health state of emergency to halt screening requirements and possibly get around the procurement rules. Plan C is to begin risk-based TB screening, which is a major change in operations, which our operations include 200 TSTs a day, and will still run out in about 6 weeks instead of 3 weeks. Plan D was a rarely used provision where the Director of Health can actually suspend an administrative rule for 16 weeks, but that can't be extended. Plan E was to ride it out, and there's a decent chance we're going to make it.
I don't think they can do C because it's...
Okay, well, let's see. We're going to hear from you what was feasible to do, but it looks like the majority of people right now would choose Plan C, which is to begin risk-based TB infection screening, which would be a major change in your operations, and you'd still run out just in double the time, 6 weeks. So that's what most people are choosing. Some, the public health state of emergency, Plan B, and another about 12% or so having an administrative rule be waived. So, okay, why don't we hear what you did?
Okay. Well, Plan C was our choice in committee, but after speaking with the Attorney General deputy, it was very clear that that was against the state law and that we weren't allowed that option, and instead opted for the next best choice, which was Plan D. The health director was able to waive state screening requirements, all TB screening requirements, for a period of 16 weeks. Under that plan, we continue to screen our TB workups, working hard not to say the word suspects anymore. Continue to screen TB contacts. We continue to screen individuals who are referred to us by all private clinics with the medical risk factors, either medical conditions or medical treatment that increase their risk of progression to active TB. And we continue to screen our immigrants referred from DGMQ, a significant number of folks that we process each day, because we find in our V1 immigrants that about 6% are truly culture positive despite in-country screening. Overall, we estimated this would be about 200 tests every week, and that would last us close to the 4-month period by which we remain hopeful that we can resume normal activities. How about the silver lining? Well, with any crisis comes some opportunity. And for our TB program, it was our first statewide effort since I arrived almost 3 years ago to reach out directly to clinicians and improve communication with our clinicians, which we think is really important. And certainly with any crisis that's ongoing, communication is the #1 tool that you need to work through problems that are facing the state. But more importantly for us, we did realize this was a golden opportunity for us to accelerate the normal 3-year process of changing the state law and to allow for FDA-approved tests for TB infection beyond the skin test, to implement a risk-based screening methodology, which was briefly attempted in the 1990s. And then in 2007, Dr. Wing did her best to push it through, and we were rebuffed by members of the community, including several pediatric groups. The problem here is that we're trying to squeeze a 3-year process into 16 weeks. but we remain optimistic that now that we have the attention of our governor, the Attorney General Office, our partners, that we are beginning to plan our public hearings already for the summer to implement risk-based screening. And here's why that's really important to us, because as was mentioned earlier, the state of Hawaii overscreens low-risk individuals and undermanages, undertreats high-risk individuals. So that same screening data I showed you earlier was broken into U.S.-born and foreign-born, and it reveals all the low-risk screening that we're doing, very sharply demarcated between the foreign-born and U.S.-born in terms of TB case rate. Particularly, you can see for students, with 126,000 students being screened and 2 cases of TB determined, whereas in the foreign-born students, nearly 50,000 screened with 50 cases. In the end, with these 3 categories of screening, we find that 95% of our active TB cases are found in 25% of the population. I remember Tom Privet at the NAR stating that placing TSTs was the New Jersey state pastime, and I think it's probably the same is true in Hawaii. Here's the same data shown graphically, and it highlights the need for risk-based screening, and I think also hints at the benefits of alternative TB infection testing methodologies that might perform better in the foreign-born population. So that brings me to the end, which is the last 2 slides and a 30-second commentary, which might be more of a rant in the end. Please bear with me. In 1920, a TB case in New York might reside at the State Hospital for TB in Raybrook. The hospital was built at an inflation-adjusted cost of $30 million and an adjusted annual state budget of $3.5 million. New York State directly funded and supported 21 other TB hospitals at the same time. TB control was a very, very expensive, high-priority, state-funded activity. That budget is comes to nearly $100 million, which is nearing the national budget of PPDWebinar. In 1950, treatment for TB required 2 years of public-funded inpatient hospitalization, which would now cost them more than $600,000 for every TB case. And the national TB case rate was 25 times higher in 1950 than in 1912. You can imagine the expenditures required to treat patients in 1950, although obviously not everyone was lucky enough to receive treatment at that time. But again, in 1950, TB control was very expensive, high-priority, state-funded activity. I guess the point is that phenomenal strides in TB control that we enjoy today have never been inexpensive, and they're a direct result of large public expenditures that have brought us to the brink of TB elimination. In Hawaii, our strategies for both TB case finding and TB prevention are based on a 130-year-old diagnostic test with unacceptable specificity and a 65-year-old medication with rapidly vanishing efficacy. Newer improvements expected in TB diagnosis and treatment will be affordable with current budgets. The future of TB control must move beyond the self-imposed budget limitations of a $2 test and a 2-penny pill. Our budgets and our strategies are tied to possibly unrealistically and uniquely inexpensive tests and treatments. So when that supply chain is interrupted, no one can really afford a plan B, at least not in Hawaii. Instead, we're sort of left to shut down operations, and that's not really a very good plan B. So, you know, it's not been like the plagues of locusts followed by the frogs, but these 2 concurrent shortages of TPD solution and INH have taught us the value of redundant systems for ordering in Hawaii of new flexibility needed for our TB laws in Hawaii, and they've revealed the resource vulnerabilities that are inherent in our current TB strategies. All of these must be addressed in Hawaii before we continue down that road towards eventual TB elimination. Okay, that's it for me, and I'd like to thank Derek Felix for some of the data included in this presentation.
Great. Thank you so much, Dick, for an excellent presentation. And rather than go to polling questions now, I'm going to introduce Margaret Oxtoby, another CDC medical officer from New York State TB controller. So, Margaret, you're on.
Good afternoon. Can you hear me?
Yes, very well.
Great. Well, I think that Dick presented some very broad issues, and John Workington also provided more of a national perspective and also Tennessee-specific experience. So I'll focus just on anything similar or different in the New York response, and we have shared the concern about the shortage of PPD solution. In contrast to Hawaii that you just heard, really basically has a very centralized program where most of the testing is done by the health department. It's not that way in the New York State area. We have no central stockpile in the state, and each local health department, each healthcare institution, specific agency, and as well as the practices seeing patients are responsible for ordering their own supplies and conducting their own TB testing. And I should mention that there's a very strong local health department system in New York where most of the responsibility for the day-to-day oversight of TB is at the local health department level. And just to show you that we have the New York City Health Department, which it comprises the 5 boroughs of New York City, and then 57 other counties in the state, each of which has their own local health jurisdiction. And again, that's where most of the TB oversight is done, is at that local level. And you can see by the colors that most of the cases in New York are in New York City area. You know, we had about 900 cases last year, and a little over 2/3 were in the city. A lot of the others around that city area, but really throughout the state and at different times. And our case rate, everyone's familiar with the fact that New York, not just New York City, but the rest of the state as well, was impacted very greatly in the late 80s, early 90s. We had extensive outbreaks with hundreds of cases in a year in prisons. We had homeless shelters, other congregate settings with rapid spread of TB, and including infection of healthcare workers and other providers. So part of the response was strengthening testing programs in these settings. And so we have gone down from 4,500 cases in 1992 very rapidly to about 1,400 10 years later, and with a much slower decline since then. So I'm not going to go into all the details of every single setting, and one of the things that if there are some people on the line that are from New York State that want to ask me some questions, it's better probably to ask them separately to us or to the regional staff in our program, and we can definitely get you any information if something's not clear. But as we know, both employees and volunteers in clinical settings, in a variety of different settings, do have required pre-employment and annual TB assessments. And that is not only the test itself, it is also the risk, the history, the symptom review, et cetera. But it does involve either a tuberculin skin test or within the past 5 to 6 years, depending on the setting, we have passed regulations that allow use of IGRAs, either the quantiferon or the T-spot in those for those same individuals. And again, because sometimes the health department organization, different components came together at different times, not all of the regulations are exactly concordant from one to the other, but the spirit is similar, making sure that there's an adequate baseline, including if a TST two-step testing, and then serial testing, preferably with the same antigen, but that's not required. In terms of residents, we try to limit residents or clients or school kids or other settings where anything is required, but as people have mentioned, long-term care facilities, nursing home patients are one group that is required to be assessed on entry. We do not have any follow-up routine. There is no need for any periodic testing in the absence of symptoms. And we also collaborate with a variety of other agencies that we do not directly oversee their programs, but provide technical assistance or opinions or support for their guidance to try to limit some of the over-testing. So we had informal reports from certain areas, particularly in some of our lower incidence areas of the state, of some difficulty getting Tubersol, but didn't have significant problems until early March. And we did put out a health advisory that gave that emphasized, along with national guidance, the prioritization for persons who are contacts, those evaluated for suspect active TB at increased risk for TB due to medical conditions, or recently arrived persons. And we did suggest that they could defer the serial testing until the solution was again available, while continuing to make efforts to order it. We have had the problem in our state of clusters of tuberculin skin test conversions, which is a reportable condition. A cluster meaning a potential outbreak is reportable to us in settings where people have changed from one solution to the other. We wanted to avoid that, given that it appeared to be a short-term problem, and so we allowed people to develop policies at a local level where they could bring back employees required to be tested after the shortage was relieved. We then, earlier this month, put out another update emphasizing that there still was a need to comply with the regulations for testing pre-employment, and that could be done, as we've stated before, with PPDs or with IGRAs, but there was no waiver or anything of that regulation. So we wanted to emphasize that, and shared further updates as we received them in terms of availability of the solutions. So we certainly are hopeful that it will be resolved, and we again are using this as an opportunity to look further at who's getting tested, and it has brought us into contact with a variety of different partners who we had not worked with as directly just recently around these issues. So, thank you.
Great. Thank you, Margaret, for another excellent presentation. So I think we've heard perspectives from a couple of our state programs. We have several more polling questions, and then we will take questions in a group. So why don't we go to the next polling question, Donna? Since the PPD shortage, have you prioritized indications for TST? In other words, prioritize patients based on their risk status, potentially, for receiving skin testing?
And Sanjay, this is Dave. We're getting so many questions that we want to start the questions. So we're going to do a couple of polling questions. But what I'd like to do, if it's okay, is let Donna just quickly tell everybody how they can ask their questions once we finish the next three. We're going to do just 3 polling questions, and then we can come back to them later.
Okay,
Donna, do you want to go over how to ask questions?
That's fine. Hi, everybody. So if you were only able to join by phone because we did reach our maximum seating capacity in our webinar, you can press the *7 to unmute your phone and ask a question, and then *6 to mute. Please don't do that yet. We are still going to do a few polling questions, but we do want to give everybody an opportunity to ask questions, so you can do it that way. Those of you that have been asking questions in the chat and the Q&A, we have been watching those and collecting them, and we will try to address all of those before the end of this session. All right, back to you, Sundri.
Okay. All right, sounds good. It looks like we have about 2/3, 1/3 in terms of prioritized indications for TST. Let's take the next polling question. if you have a prioritization scheme, what procedures have you implemented? And you can answer all that apply. Have you stopped all LCBI testing? Stopped routine LCBI testing, or just used TST in high priority testing, like, for example, contact investigation?
And I think you can see here, Sundari, that it looks like it's very interesting that we're seeing a couple different things. One is that we're seeing that really only using skin testing for those high priority testing, which I think we'll get into in a couple minutes, and also a lot of stopping of routine LCBI testing. I think Dick's presentation really, I think, emphasized some of the obstacles that can occur, but the importance of being able to do that, especially in a time where there is a shortage.
Right, exactly. It looks like the majority, 80%, are only using TST in high priority testing situations now. Okay, let's go to the next question. If you've postponed LTBI testing in this situation, are you planning on resuming testing with the TST once the shortage is resolved? Yes, as soon as the TST antigens are available. Yes, that next testing cycle. No, we've switched to IGRAs. Yes, we're testing with IGRA, but we'll retest with TST once again, or other. And I think what we could have asked maybe is whether they would continue to prioritize individuals who are high risk, having learned from this opportunity. I don't know, we didn't ask that, but looks like the majority of people would resume testing. And again, we don't know if you'll resume at the same level you were doing before or not, but you'll resume. Okay. All right, what do you think? Should we stop there, Dave, or did you want to do one or two more?
I think we're getting a lot of interesting chats and questions being posed to it. And I think this is the time, because we want to make sure we have plenty of time to answer questions and ask questions, because, that's one great thing about the TB community. We're a small TB community, and it's always nice to be able to share what our experiences are. So, if I can, let me start with the questions that we're getting on the chat. So the first question we're getting is, can we specify exactly what caused the shortage? And at least personally, and I turn to John too, but in my conversations with the company, at least Sanofi, it is not clear, and we have not gotten, at least I have not gotten a clear answer of what exactly caused the shortage. John, do you agree, or?
Dave, I agree.
Yeah, so I mean, I think at this point, asking what caused the shortage, we don't have an answer, and I have to be honest with you, I'm not so sure it really matters. I think the question is, what can we do, and how do we adjust as a community? So, I just want to put that out there.
Right.
And then, the other question we're getting a lot of is, what to do with, like, in hospitals and facilities where skin testing, or at least LTBI testing, is required on an annual basis. And, I think the first thing we would say is that it's important to assess, is that still necessary, as the CDC guidelines pretty much point out that, the need to do testing and how often is really based on the risk assessment of your facility. And that should be adjusted that way. But there are a number of facilities right now that there is not enough there's not enough antigen. So I do know that many have actually postponed at this point, their testing, and they're waiting for the antigen to come back, and we'll resume it at a later date. I'm seeing some discussion. I wonder how the rest of you guys feel about some of the hospitals that think about switching to IGRA, but I think you'd agree it's a little difficult to go from skin testing to IGRA, because you don't want to keep going back and forth. Sundari, do you agree with that, or?
Yeah, I think absolutely, and I'm going to have John speak to that as the author of the MMWR as to why that might be a problem to go from one test to another during serial testing.
Right. So this is fairly subtle, but I'll talk about serial testing and what happens when you switch around between the testing methods. Of course, there are the administrative problems that you don't just suddenly one day buy a different product and change all the processes. You do have to retrain people. You have to put different kinds of tracking systems into place. Those little nitty-gritty problems become big nitty-gritty problems if you're dealing with thousands of employees in a major hospital. And even in a smaller setting, when you don't have that many personnel to work on infection control, it's still a big deal to switch, certainly between the skin test and the blood test, but also even in terms of setting up the ordering practices to switch between two products in the same category. And then there's the fact that even though all of these testing methods and products are comparable in cross-sectional studies, on the individual basis, they behave a little bit differently. So here's an example. If you had 1,000 people and you test them all with Aplasol and you test them all with Tubrsol at the same time, you might find that you get 5 reactions with Tubrsol and 4 reactions with Aplasol, very close numbers, but they won't be the same 5 and the same 4 that are reacting. So whenever you switch between products and you're testing personnel over and over, you get some weird fluctuations of results that you have to deal with. Then there's the added fact that we still don't know that much about how well do IGRAs behave in serial testing programs. Certainly with TBSC and Task Order 18, which still doesn't have its results published yet, there were some very disconcerting discoveries about the stability of results with IGRAs, both the quantiferon and the T-spot. So in switching, it raises a lot more problems than perhaps you'd get if you were just to defer testing for.
All right. Thanks, John. Thank you very, very much. Why don't we start for 1 second? Does somebody on the phone have a question? If you just push *7, and we'd be, tried our best to answer it, or any comments, please.
Hi, I have a question.
Please, go ahead.
Hi, this is Diana Elson calling from ICE. How are you?
Hey, how's everything going?
Hi, Diana.
Hi. So I really appreciate the discussion, and John Workington, thank you for including the discussion of corrections. So as many of you know, we have a nationwide population of detainees that are all foreign-born. And so I would assume that you would consider them all falling into a high-risk population. Detention facilities do have requirements to screen, either as part of ICE detention standards or state requirements. Our standards are usually to screen for TB disease. Local jails, we are hearing from local jails in all regions, and they are starving for guidance. So I'd encourage TB programs to please reach out to your local jails with guidance. They are coming to us for guidance. We're trying to get an interim solution approved, and it's probably as cumbersome as getting an order from the governor as well. Most ICE detention standards require a screening at intake, which is, exceeds the time frame for CDC guidelines. So I wanted to hear from all of you and see, what we suggest. We are proposing, allowing facilities, and these are mostly facilities that are not those that we staff that use digital radiography, but to allow screen with chest x-rays for TB disease, but of course that's going to be very costly. It will also increase the time frame. We'll run into issues of people being transferred possibly before the screening is accomplished. We do transfer people within the system across jurisdictional lines frequently. So this is a huge, huge burden for detention facilities, and please keep that in your awareness. Any suggestions that you can give for high-risk populations in detention facilities?
Yeah, this is Dave Ashke. I know in Florida, when we're now dealing with our jails, again, a little different than the detention, but one of the things that we are switching to is obviously we're still using a risk assessment and we're doing the questionnaires for active disease. But when it comes to infection, we are switching to IGRAs. And again, if you look at IGRAs, a lot of the problems occur if you're doing serial testing. I think that's where it gets a little more difficult. But for our cases where, in our congregate settings, in corrections right now, we are suggesting, because there's such a turnaround in our jails, the switch to IGRA. Of course, that has caused some issues as far as availability, and cost. But that is an option. For our prisons, again, we are, where you have people there for a long time and they're doing annual testing. We're just holding off unless there's some sort of a symptom. And then for new admits to our prisons, we are doing IGRAs up front, and then we plan on repeating, if the facility uses skin testing, is going back to skin testing once it becomes available. I'm not so sure if that helps or not, Diana.
Well, we discussed IGRAs, but a lot of local jails, they don't have the training, they don't have the CLIA-approved lab to do them. So for them to what they can implement themselves, I don't know. We're a little bit.
I agree. One of the things that's interesting, just as a kind of an aside, just a little, one of the things we're finding is that as we're looking more and more to IGRAs, and I see this on the chat, and just to make a comment, it's amazing how the prices that were being offered is really tremendously going down, to the point that it is getting very close to the cost it would, for 2 steps and all the extra, not for 2 steps, for skin testing and having 2 visits, and all the extra quote-unquote x-rays that we think we do because of quote-unquote false positives. So I do agree with you that there is an issue with training, and it takes time, but the big thing everybody always talks about is the cost. But we're seeing tremendous drops in cost beyond what we would ever have thought. As a matter of fact, at least on our state contract now, we're being offered $25 for a particular test, which is really made us rethink about our what testing we're doing. So I suspect if the price was right, especially long term, then it would be worth your while to consider retraining staff.
Yeah, Diana, this is Sundari. I just wondered, what's the main obstacle with doing that in your facilities?
Well, no, it's not our facilities that we staff. It's the 250 local jails nationwide that we do not have direct oversight of the medical care. They do their own procurement. They probably don't get special pricing. We don't train them. They would be, they're under their own jurisdictional authority. And so, whatever they're dependent on whatever relationships they have with their local health departments for technical assistance. But they're coming to us because they're having trouble meeting standards.
Yeah, I think your suggestion that the local and state health departments on the line reach out to their jails and partner with them in trying to find the way forward is probably really important. I'm sure many of the programs already are, collaborating with their jails.
All right, thank you, Diane. Thank you very, very much. Do we have another question on the line, or else I have a couple questions here. But,
yeah. Hi, David. Mark Lobato.
Hey, Mark. Thank you very much. I appreciate you. Please, you've been very, very busy.
Yeah, I've been following the chats, and it's very interesting because I think the flavor of actually how this is impacting the programs is reflected in that. One theme that's been fairly prevalent is the regulations requiring either annual testing or either in healthcare facilities or corrections or long-term care facilities. So even though we recommend to defer some of this testing during the shortage, it may be very difficult for programs. So one of the nurses suggested that CDC or TMCCs perhaps host another talk more of the how to do and how are programs dealing with these regulations, and how are they dealing switching over to IGRAs and the issues of different solutions of PPD tuberculin.
Mark, you worked that out perfectly. We planned it and practiced it well, but you're exactly right. Coming up relatively soon, we'll get out all the announcements, but I know from the SNTC's perspective, our next grand rounds will be exactly that, on practical issues in LTBI, specifically on the IGRA. In fact, we got a lot of questions specific to the IGRA that we thought would be beyond this webinar, but very, very important, and that will be coming real soon, and I totally agree with you, including, and we'll take you up. Matter of fact, I think you just volunteered yourself, but it's very practical as far as guidances and regulations. So thank you very much, Mark.
All right, thank you, Dave.
One of the questions that was brought up on the chat was that, the question was Sanofi's recently announced 10-dose vial program available to private providers or to public health? And again, Sanofi does, they do apologize for not being able to join. They would have liked, they just had some conflicts. But they did send out a message to me for that the 10-dose vial is available to practitioners, or as they call them, end users, meaning either public providers or private providers who use it, and they just call the 1-800-vaccine. One of the things they asked, of course, is that that there may be some interruption because of the demand, but we're already seeing on the chat that people are getting it, and I do want to clarify something I said before about the price. That was not through the company. The company's prices, from what I understand, are the same. They also said that they're hoping that the 50-dose vial will be out by the end of May. And as you also know, and we have Steve Richardson on the phone, if you have a question for JHP, who's very, very kind to join us, they also have an allocation program to get applesol and are there to, if you need it, to make it available through their system. So I just wanted to say that at least for the question, it is available to both private providers as well as public health, and I'm also being told that it is also being distributed to the wholesalers too, which was one of the questions. Was it only to the providers? So I hope that answered that question. Do we have another question on the phone? If we could go to a question on the phone. All right. Another question we had online is some universities require TSTs for nursing and medical programs. Do you think this should be limited? And I don't know if John wants to or Mark want to answer this, but the testing that we do in among healthcare workers is a little different because we serve a couple different programs. The reason we do it for a couple different reasons. One is that obviously if a healthcare worker should develop TB, it could be very catastrophic considering the significant number of immunosuppressed individuals that we deal with. So we want to know that if we're infected, that we would hopefully try to take the meds to prevent it. But the other thing is that frequently, if there is a case of TB, we need good baselines among our healthcare workers, and that's why it's important, as John pointed out, not switching back and forth and having good baselines. So I don't know if John or Mark want to, or Sanjay, you want to comment on limiting in healthcare workers, but I'm not so sure necessarily that the move would be to limit it. I think it's more important that we base it on the risk assessment of the healthcare worker and the facilities they work in, and base it on that. Do you guys agree?
Well, Dave, this is John, and I would just add that it really needs to be a local decision because the healthcare worker in Miami is not the same as the healthcare worker in Des Moines, and is not the same healthcare worker as in San Francisco. So really, I think that should be a collaborative decision between the infection control practitioners that work in those institutions and the TB control authorities that serve those jurisdictions.
John, I totally agree. Thank you very, very much. I appreciate it. I guess, we got a number of questions, and I know, John, you addressed it, but we're still getting, the question switching between Tubasol and Applesol. And I guess just to clarify one more time is just that, I think you'd agree that you're always better off, looking at apples and apples. It makes it easier to interpret, if I'm correct.
Well, it does, Dave. I think that if you just have patients coming through a clinic and one-time testing, that the impact of switching between the two antigens is probably not substantial. But if you have serial testing where the same person's getting tested over and over, switching between the two antigens probably does make a difference. So if your testing is, for example, in an immigration clinic where you don't anticipate that very many of the patients are going to get tested more than once, the switch between antigens should not make a substantial difference.
I agree. it's that cereal, but I totally agree. All right, do we have another question on the line?
And there is it's *7 to unmute your line.
Thank you, Sundri. So,
Hi, we have a question.
Please.
We were considering switching to the quantiferon gold prior to this shortage on new hires, but then annually doing TB skin testing, basically due to the availability of the staff to do it. Is that a good option to do those two things?
Well, this is John speaking. I think it's an option, but if I were running a program, I would not want to go there because it's two different kinds of tests. And if you're using the quantiferon test or T-spot, the other IGRA that's commercially available in the United States, and then you use a skin test later on, then you raise a number of issues. First of all, the concordance, the agreement between IGRAs and the skin test is only fair at best, and so you're going to get probably a different result more often than you'd like to see. And the other problem is that with that kind of a program, you're not allowing for the fact that once that person comes in for the third test, in other words, the second skin test, there could be some boosting, and you didn't have any two-step testing at the beginning to, diminish the effect of boosting.
Right.
So I think that it would be opening the door to a whole lot of unexpected problems.
Thank you.
You're welcome.
And where are you calling from?
North Carolina.
North Carolina, okay. All right.
And do we have another question on the line? *7 to unmute. Well, we had a question that was sent. We had a number of questions that was sent in, but a number in particular were about, discussing recommendations for screening of newly hired healthcare workers during the shortage. Sundri, do you want to discuss it, or would you like me? I mean, just as far as, what are different groups doing? I mean, as far as some are, I think, postponing it, while others, I think, are using like an IGRA, at least initially, and then once the skin tests are going back, once the antigens are available, would go back to their normal routines. Do you agree with that, or anything else?
Well, Dave, this is John. I think if you look at, for example, the recent MMWR publication, we've already listed what the options are from the federal perspective, and we made those options very broad to give leeway for the state and the city and county health authorities to make their own decisions, and those decisions would be based on availability of testing methods, expenses, and the epidemiology of TB within that jurisdiction. Otherwise, we can't comment much further on what's recommended from the national level. Also, we don't have a survey method immediately at our fingertips to tell us what are people doing, so I think it would be more informative, to start with what we've heard from John Workington and Dick Brostrom and Margaret Oxtoby. That was a sample of 3, but I bet there's a different approach everywhere.
I totally agree. Thank you very, very much. Another question we're getting, and just, again, we're not going to use too much on IGRAs, but, the question always comes down, what about children less than 5, especially with the limited data from IGRAs? Is skin testing still like the gold, the most recommended standard for children less than 5? And I think we'd agree, given the limited data, that the answer is probably yes.
Here, I'll speak.
Yeah,
Sundri
Phil,
or John?
Phil is going to speak to that.
Hey, Dave.
Hey.
The recommendation, still stands that skin test is preferred in children less than 5 just because there are a lot more data. But it is clear that IGRAs are an acceptable alternative, and clearly if you don't have the option of a skin test, IGRAs are acceptable.
Exactly right. I think it's, we have a lot more data for obviously individuals, over the age of 5, and there's still the Red Book still talks about children under the age of 2 that the IGRA not be used. But I think again, it's one of those, if you have no other choice, you just use it. But I think you'd agree with limited, understanding that there's limited data. All right. Do we have do we have another question on the line for?
I have a question, please.
Please go ahead.
Oh, this is Melissa from Kentucky.
Hey,
Quick
Melissa,
question:
how you doing?
if a facility switches to using the IGRA testing for employees, that of course you would do that one time, and that would alleviate the need for initial two-step. Is that correct?
That is correct, because skin testing can cause a boost because you're introducing an antigen into the skin, and it can stimulate the delayed T-cell hypersensitivity to react more strongly the next time there's a skin test. But when you do an IGRA, you're not introducing an antigen into the patient, you're just collecting some blood. So that's why the two-step testing is not part of serial infection control programs with IGRAs.
Okay, thank you.
You're welcome.
Great. And we're being asked on the online. I have a question here to address the serial testing of healthcare workers when switching to initial IGRAs, annual IGRAs, or annual risk assessments. And I'm not so sure how much we really want to go into, because I think this is a whole other webinar, especially with some of the more recent articles and studies looking at serial testing in healthcare workers, especially overseas and in the United States. Other than to say that, and I would turn it over to you guys, but I think the issue comes down to that we're still learning on that, and I think it's something that we will probably be discussing in much more detail with the next webinar, unless John or Sundri, you want to comment a little more on that.
Yep. Dave?
Yes, please.
This is John. I'll interject with a little observation about producing skin test antigen. Even though the question hasn't come up, we discussed it on Friday. Like, why don't we just make more skin test antigen? And the short answer is, it's not that simple, because the antigen is very difficult to produce, and the standardization process is detailed and precise. About a decade ago, I surveyed the two manufacturers of tuberculin solution, and I was able to estimate that allowing for 10% wastage, we give about 18 million skin tests per year in the United States. And even though TB cases have decreased, the policies and regulations that affect all that skin testing haven't changed that much. So I'd be willing to bet that we're still probably at, at least 15 million skin tests per year in the United States. That's a whole lot of skin testing, and probably most of it doesn't have a lot of public health impact. But back to the production of tuberculin skin test antigen, we would love it if the producer of Aplasol could just snap fingers and instantly turn out a few thousand more vials of their antigen, but that can't be done. Also, the question comes up, well, why don't we just import something different? And I'm not going to wish that on anybody, because around the world, quite a few different skin test antigens are manufactured, and they're standardized in their own countries according to their own standards. But if we were to get one of those approved in the United States, the approval process itself would be very long. I'm sure that it would take more than a year, although I don't know all the requirements. And if we did get another product into the United States, even if it met specifications, which would be very difficult to do, it would still behave as a third product. It could not be identical to Tubrsol, and it could not be identical to Aplasol, just in the same way that Tubrsol and Aplasol, even though they give comparable results on a population basis, they do behave differently if you go patient by patient. So that's just some questions that hadn't been raised so far.
John, I really thank you very much. I mean, because I think there was that issue that people felt like I don't understand, why can't we make more? Why don't we import it? I think it's so important. That's where, like, skin testing antigens, it's so funny. I was saying this the other day, that we really have had, in recent years, almost an inundation of how IGRAs work and the whole, and how they're produced. Whereas with skin test antigens, which we've had around for over 100 years, actually, I can't remember really the last in-depth, or discussion on the difficulties with it. And I think that's brought a lot of this to light, and how vulnerable we are if something goes wrong, and actually how lucky we've been that there hasn't been more going wrong, and what the process process are to standardize. So, John, I appreciated your discussion very, very much. You know, one of the questions we're being asked is what is the current date predicted for the resolution of the shortage? And, you know, as you guys know, and has already been stated, it's been kind of going back and forth. You know, we were first told that late April and May. When I spoke to Sanofi, at least, my understanding was that they were hoping to have the, you know, right now they're having the 10-dose vial out, and they're hoping to have the 50-dose vial out relatively shortly. But even when that comes out, I think you'd agree there's a lot of back order issues, and it may be a little while. But they're, you know, in relative terms, it seems like they're at least discussing that they're hoping it will be relatively quickly.
Questions with our colleagues at FDA. And, wow, and we didn't discuss them with that dog, but I'm sure. But that dog also has some very relevant information for us. Our colleagues at FDA have a strong role in the way that these products are standardized, the way that they're labeled for sale, and the manufacturing practices, but they can't in any way direct or regulate the availability of these products. And indeed, our colleagues at FDA only will know as much as we do, which is what the producers tell us. And that's what you were telling us just now, Dave.
Exactly. I mean, you know, it's kind of a hard situation, but we've just got to keep our fingers crossed, you know. Do we have another question on the line? All right. You know, one of the questions we're getting is, a bottom line is that, you know, again, there's some IGRA questions, which I really want to emphasize. I think is a whole other webinar, which we will do shortly. But, you know, one of the questions they were asking with IGRAs, which is that when you're doing IGRAs for a contact investigation, just as you do with a skin test, do you do initial IGRA and then 10 weeks, post, to make sure that there is no quote-unquote conversion or delay in responding? In general, the answer is yes, if I'm correct, John.
That's what's in the recommendations now, with the caveat that's in the recommendations that we still don't have a lot of data that would tell us what is the time between infection and the conversion of an IGRA result from negative to positive. So the presumption is that it's in the same 8 to 10 week window that would be for skin testing, and a tiny amount of data supports that assumption, but I think it may play out to give a slightly different number eventually when we have more experience.
I agree. Hey, John Walkington, are you still on the line? *7?
Yes, I am.
Hey, John, me and you had a conversation a little while ago, and I'm going to put you on the spot, but I'm seeing a couple people on the chat and asking questions similar to this, which is essentially, like we were kind of alluding to and you alluded to, when something like this happens, it makes us re-examine. And you put out a very, I think, an interesting question, which is, do you think that this is going to make people really re-examine the role of skin testing? And do you think that potentially, this could be, quote-unquote, the death to skin testing? Obviously, I'm saying that somewhat tongue-in-cheek because I think it's a little early. But there's a lot of questions, and I think something like this makes people really assess, why, the limitations of both skin testing as well as IGRAs. But I just was wondering what how you felt about, what this may do to skin testing.
Yeah, thanks, Dave. In our own program here, we've had to make, tough decisions like other states and local jurisdictions have as well about choosing between rapidly accelerating our implementation of IGRAs versus holding off on that. We have enough information, I think, about the IGRAs and healthcare workers, although it's not publicly released data, to suggest that that's not a good way to go at this time, at least with the currently available IGRAs. For screening healthcare workers, the vast majority of whom really are at relatively low risk. And I think that's kind of the caveat. I think that much of the testing that we do out of an abundance of caution with TSTs is probably overkill, and it's done at the expense. It's done really without thinking much about risk factors. And what we see in our own practice is, even with TB suspects and confirmed cases, is that the history is the most overlooked part of the whole assessment process. And too much is hinging on the results of either one of these tests, whether it's an IGRA or whether it's a TST with either of the two products. So in the meantime, since there is no gold standard, there is no perfect solution for the TST, I think there's still a role, particularly until we have more information about our pediatric populations. So I also think that it's critically important that research continue. And I hope that some of the players that are in the business of developing IGRAs will continue to refine their products and make them more accessible from both a financial and distribution standpoint.
You know, I totally agree. I mean, and one of the big things that I think, would also kind of dictate this is, at least now, do you have access to IGRAs and, and how it's being used? So if it's okay with you, for 1 minute, what I'd like to do now is to switch over to some polling questions, about, IGRAs and, IGRAs and how you're using it. As a matter of fact, if we could do it, Donna, if you don't mind. Okay, we did the first one.
Great, yeah.
Do you have IGRA testing available to utilize? And one of the things, John, I think you'd agree, is that you're seeing now that almost 65% of at least our participants do have IGRAs available, which is quite a difference from just a year ago when we had a similar webinar. Sundri, what do you think about that?
Yeah, I think you're right about that. I think I don't recall exactly what the breakdown was previously, but that definitely looks like more programs have access to IGRAs. So we have got two questions going now. We have the second one. If you have IGRA testing available, do you use it as your primary mode of testing, secondary, confirmatory testing for those who are THC positive, or don't use it at all? And this is interesting, too, because we have a full 1/3 who actually have testing available who aren't using it.
Yeah, I mean, exactly. So you're seeing, you're seeing that, as you're saying, about 70% of individuals now are using the IGRAs for LTBI testing. So to get to what kind of John was alluding to, we are definitely starting to see the switch, and you just wonder how much this shortage is definitely, is significant in, let's say, initiating or at least, encouraging or at least some programs are switching over to IGRA maybe before they would have otherwise. So it's kind of interesting.
And again, we see, as we kind of had indications before, that a lot of programs are prioritizing who gets tested.
And then we put up on 14, just out of interest, since the PPD shortage, what changes have you made to your practice? And interestingly enough, only 4% say they switched to IGRAs, which means the vast majority were using IGRAs before, if you put this together. Where it says, I would say that about 17% of people have switched PPD antigens, applesol for tubasol, which again, I think is significant. I was very impressed with how many individuals were using tubasol instead of applesol.
Yeah,
and,
it was almost 90% tubasol.
What I think is really excellent is that 78% of individuals now are starting to prioritize their testing, which I think, if there's one thing that came out of this, I think that's so important.
Right.
I'm sorry.
No, I was just saying, from Dick and Margaret's presentations, that's going to be the silver lining potentially, is really identifying those that are high risk for testing to start off with, and this may have started that whole process in places where they haven't been prioritizing at all yet. And then I want to note that as far as switching to IGRA testing, that may be really difficult for programs that don't have the capacity for it yet. So that might be why there's only 4.5%, is that it takes a certain amount of startup time, laboratory quality assurance, in order to even perform IGRA testing. It's only been a few months that we've had this shortage.
Just to address what you're saying, if the IGRA testing is not your primary, which is here it is, if IGRA testing is not your primary mode of LTBI testing, what's the reason? So,
there we go.
Yeah, thanks.
TST is still tried and proven. IGRA is too expensive. IGRA is too difficult to obtain or perform. not enough known about IGRA performance, and too many indeterminate results.
So it appears that that IGRA is too expensive, and I totally agreed with that. I mean, I got to be honest, we're very surprised, and I see a couple people chatting. It's not just us. That with some negotiations, because there is some competition now, we were really able to negotiate a very low price. And I suspect, like everything else in this country, that I believe that as the demand increases and as people are using it more and more, that price will come down.
Yeah,
so
and I think, Dave, it probably has to do also with the numbers of patients being tested, and then maybe the test might be less expensive in areas where they're using the test more. I also want to just note that people on chat are asking for a risk assessment questionnaire. And I'm sure there's numerous different such questionnaires that are out there, and wondering if you guys could post some on your website.
We can get that done, sure, and I will work with the other RTMCCs because there's a lot of really good products on for that, and we'll make sure that they're available.
Right, and there are some that are already, I think already out there that RTMCCs have produced. So, and they may already be on our combined website, so the product's website, that is. So maybe, Donna, if you could just put up the product website for people to access. They're probably already there. Great. Did we have another polling question, or did you want to answer some of the other questions that have been asked?
Let's see if anybody, after these kind of questions, let's see if anybody else, we have a couple minutes left. Do we have anybody else who wants to ask a question on the line?
Star 7.
Hey, Dave, this is Kevin Fenley.
Hey, Kevin, what's up?
Not much. Just had actually more comments. I'm sorry I've been going in and out, so I don't know if I might have missed this in the discussion. If so, I'll apologize ahead of time. But one of the things I've seen and heard in the calls I get is that there's two roles for assessing LTBI. One is for the individual in terms of screening. The other is more population-based for surveillance in hospitals. And one of the issues I think people get confused with is that they often don't go back to the CDC's recommended risk assessment, and they'll be in a very low-risk facility, but they want to get, they'll get a quantiferon, then do that repeatedly every year for all the healthcare workers that are at low risk. So, a lot could probably be saved if you just followed the basic CDC risk assessment in the guidelines for preventing transmission. The other issue that I hadn't been aware of until just recently is that of timing of the of using the IGRAs relative to the TST. And there's a group from Spain that's published on this, one in the Scandinavian Journal of Infectious Diseases back in 2011. And, we're probably going to be seeing some more interesting data come out about this, but there's probably, a similar window for the quantiferon, maybe even longer than for the TST. So people should just consider that they may, if they're being used in a contact investigation to, wait at least 8 or 10 weeks.
Without a doubt. Kevin, thank you so much. And I think you brought up a great point, which, I think, we're always looking for better tests, but there's ways to make the test better. And the risk assessment is not just about learning who we should screen, but it actually makes the test better. I mean, it's all based on Bayes' theorem, which is that whole concept that the accuracy of a test is really dependent on the prevalence of the condition in the population, which essentially, to make it simple, and I always like to use this, is that if you test 100,000 men for pregnancy with a beta HCG, you're going to get a number of positive tests for pregnancy, but I hope the men are not pregnant, I think. And, the whole idea behind that is that if you have a positive test in a population with a low risk for the condition, it's more likely the test is falsely positive than truly positive. Whereas if you test 100,000 women for pregnancy with the beta HCG, if you get a positive test, it's more likely to be true. So, Kevin, your point is so well taken, and I think that's one of the most important messages, is that we really got to get back to our risk assessments and making sure that we're using these tests in the population where the test could be most effective. It gives it its best chance. And I think not only will that help us with, conserving the antigen and everything and saving money, but it makes the test, much better. And I can't emphasize enough, that the risk assessment, as John said, is not only something that will help the test, but it's something that's very, very dynamic and is constantly changing. We have to reassess that. And that's why, like you said, Kevin, going back to those CDC guidelines are so key. So any other, do we have another question? We have one more question I have, and then we're running out of time, and then we're going to close up. But, there's an interesting question that came up on the chat that says, it appears the shortage started with Tubasol, and that when customers started to switch from Tubasol to Applesol, there became a shortage of Applesol. And it says we've seen this type of trend in other, situations. And the writer says this poses a question: if a large number of customers switch to the IGRAs, will this cause a shortage of an availability of IGRA tests? And John, I'm hoping that it's not the same process as to do an IGRA test it is to make tuberculin skin antigen. What do you think?
Well, I can respond to that partly. It's too bad Jerry Mazurik's not on the phone because he knows more about the technical requirements for producing the polypeptides that serve as antigens in the IgRAs. But those are synthetic polypeptides. And the scale-up of production probably would be relatively straightforward. Now, that doesn't mean that necessarily that the company is in a position to do a scale-up, but the limitations in terms of the standardization that we have to do for skin test antigens are just not the same. So I think that the scale-up is more feasible. You could say that it's more elastic, and the company could be more responsive and could produce more test kits more quickly than we could get more skin test antigen.
Well, John, thank you very, very much. We're about to close out. We're coming to the end, and I just wanted to first thank Sundari. Thank you so much, and CDC, and John, and Dick, and Margaret, and John for participating and putting this all together. I think we'd agree that, as I was saying before, the TB community is a very close, tight-knit community. And when we're having an issue, we feel it's very, very important that we all get together and share our experiences, share our knowledge, so that we could treat our patients the best possible. And that was the whole idea of the webinar, was really to help support the Health Alert Notice as well as the MMWR, and take a little time to share with us what's going on and making sure that you guys are up to date. So I want to thank you so much. I want to thank Sundari, and I'm going to turn it over to you in a second, Sundari, but I want to thank everybody for participating today, and I want to remind you that remember that this webinar, if you didn't get a chance to see it, will be it'll be archived, and you can access it through the SNTC website, as well as the handouts are there too. So we really, really want to thank all of you. Again, we want to thank our brother and sister RTMCCs for helping support this. And other than that, I just want to remind you that we're always here for you. So thank you so much. And Sundari, I'm going to turn it to you.
Great. This was an excellent presentation by everyone. Again, thanks to all the speakers. And to Donna Setzer, who really pulls together these webinars and makes them so easy to present. Now, Dave, thank you for the idea for having this webinar. All those questions that haven't been answered, we will run through them and try to get back to you by email if there's some burning question that actually has had no response. And you can always email us as well. I think, Dave, you'll be putting out the date and time of the next webinar where you're going to talk more about specific tests, because I did notice there's a lot of questions about quantiferon and T-spot and their use and how they're interpreted and that. Do you have a date yet for that?
Not yet, but what's happening right now is Donna, we're just going to send Donna to Hawaii to deliver some of the skin test antigen. Once she comes back, then we'll get everything set up.
Yeah, I noticed that a lot of people on the chat wanted to go to Hawaii, so I'm sure you have an invitation from Dr. Brostrom to visit the program. So, okay, thanks very much, everybody, and we'll try to get back to you with questions that are unanswered, and hopefully there'll be an end in sight to this problem soon.